All right, welcome to another week of ICU Doc Talk. Thanks for joining me. This week, I'm just going to tell stories. I know be honest, that is what people want. They just want stories. They just want exciting medical stories. So I'm going to give it to you today. All right, here we go. First before getting to that, you know how like podcasts will like start a plea for like we need to keep the lights on, and they'll do a several weeks run where they need donations. I want to say the exact opposite. I don't want your money, and not only that, I have created no venue for you to give me money to run this. This is specifically a public service. There's no commercials. I don't have any endorsements. There's no pay advertising whatsoever. So my medical opinions, and I often, as you know, give political opinions and opinions about society, all that stuff. It is just from me, one guy. That's it. Okay, so this is the part of the podcast where it might start out that way. Hey, we want money. I do not want your money, and there's no way you can even give it to me. Anyway, so let's go with some stories. So these stories are going to come from many different cities and many different hospitals. Some are in the past, some are more recent. They are all anonymized. I will keep the gender of patients out. I will keep the age of patients out. These are 100% anonymous to protect identities. But they are all real stories and that I have been witness to. The first story was from a trauma hospital that I worked at. It was a level 1 trauma hospital, which means we get a lot of traumas, a lot of really severe traumatic injuries, gun injuries, penetrating wounds, suicides, things like that. I guess I should have a trigger warning that this podcast will involve acts of violence and gore. All right, so first up, it was late night. It was probably like 1 a.m. And I heard about a patient who had drowned in a lake, a large body of water, who was out late at night. And this person, the patient, was with their significant other. Both these people, they were found. Someone called in that they went out like paddle boating or something like that, and they never came back. So the Coast Guard, or whatever it's called, the Coast Guard was out there looking for, and they found the patient. They found the patient's significant other had died, but this patient, they started resuscitating, and they must have had a pulse or something because they kept going. And here's the story I heard. Oh, we have a patient coming in who's young, like 19, 18, and they've been doing chest compressions for 90 minutes, and they're still doing them, and they're going to crash them to the OR to put the patient on ECMO. So I was a resident at this time. My first thought was, that's a ridiculous idea. That's just a dead body. Someone who's resuscitating for 90 minutes is a dead body. That's just doing chest compressions on a dead body. That was my first thought. So anyway, so we're like, all right, a surgeon wanted to put the patient on ECMO, and I'm like, all right, it's fine. Whatever. So we're sitting waiting for the patient. The patient comes through the doors. They have a Lucas machine on. I made a TikTok about a Lucas machine. It's basically, imagine like a big piston. So back it up. So when we give chest compressions, someone gets on the chest with two palm, a palm on the chest. And we're going up and down to the chest to circulate blood. Well, there's a machine called the Lucas machine in the United States. Anyway, and we call it the Lucas. I'm sure there's other brand names. It's like, imagine an arc that goes over a patient's chest and a piston that goes up and down and pumps on the patient's chest. It's a machine. So this patient comes in on a Lucas. It's a very small person, the patient. And they are just thumping up and down. I mean, the body is rattling up and down from the Lucas. It looks very violent. If you haven't seen one, you can look up a video if you want to see what this looks like. So this patient's been on this Lucas. They were on a helicopter. And I'm just like, I was just scoffing at this because, and I know that sounds insensitive, but it was like, why are we doing this? This is completely futile. This is pointless. This patient's been getting chest compressions for 90 minutes. There's no reason to do this. This is an enormous waste of resources. This patient is dead. So we bring the patient in the OR, and as the anesthesia team, we assess the airway. The patient's already intubated. Tons of just pulmonary edema and blood coming out of the breathing tube. Just all this stuff backing up. The patient obviously does not have a pulse. So we're like, okay, so we don't really. I don't remember all the anesthetic that we did. We didn't do that much anesthesia because again, it's like it's a dead body. You don't really need to put anesthesia on a dead body. And I was just skeptical the whole time and just had a bad attitude, which I shouldn't have, of course, right? I shouldn't have that. Anyway, so the surgeons start cannulating, putting a patient on ECMO, which was a a procedure I wasn't that familiar with as a resident. Now I am because I do it myself. I put patients on ECMO and I take care of patients on ECMO. Anyway, so they put a big line, a cannula we call it, or a large catheter in the groin, two in the groin, and on either side, and then we get the heart back, and the heart starts pumping, and we're like, oh great, so we stop the nucleus, and everybody cheers, and again I'm still all skeptical. I'm like, well, the heart's back, but the brain is gone. There's not going to be any meaningful neurological recovery. Which isn't, just my skepticism and cynicism. It didn't make me like not do things. Obviously I was participating in the care and helping resuscitate the patient. I wasn't, refusing. I don't want to give the wrong impression. Anyway, so we got the heart back and the patient's on ECMO, and so that's the end of that. So the patient went to the ICU, and I was like, well, the patient will be brain dead, which is death, right? Brain dead is death. So that patient left the hospital like a week later, completely alive and totally neurologically intact. I mean, yeah. And I'm sure what you were screaming at me this whole time, if a drowning victim, a young patient who drowned is a very good candidate to put on ECMO, because their body temperature is low, and that provides neurological preservation. So that's a very good candidate to put on ECMO. So that's one thing I didn't really have a good insight in as a resident, as anesthesia resident at the time. So I learned a lot from that, right? So you do need to be selective with who you put on ECMO. But if there is a young drowning victim, it doesn't matter how long you've been doing chest compressions. Bring them, send them to a hospital that can put them on ECMO, because they can survive, and they can have meaningful recovery, and they can live the rest of their lives. They can. Doesn't mean they will. But that was a valuable lesson I learned from that. All right, this next story involves children and extreme violence. It'll probably take me 7-8 minutes to tell this story. So if you don't want to hear this, skip ahead that much. It's graphic, okay? So this is disturbing. So if you have I would have a low threshold to skip this story. Okay, about 6 or 7 minutes ahead in the podcast. So again, this is when I was a resident, and I was in the trauma bay doing anesthesia up and down. I'm in the OR doing anesthesia, and then we also, when there's a bad trauma in the emergency department, we have a pager that goes off that I go down in case that patient needs to immediately go to the OR, so that I can take them with the surgical team. So I help out in the emergency department all the time there. So it was a gunshot, so there's a lot of gang violence where I did residency, and gun violence. So I come into so it's a code, trauma code, gunshot. That's all I know. So I come in, and come into the room, and I look on the left in the resuscitation bay, and there's a child that's looks about 12, and that's getting chest compressions. And then I look right across in the other resuscitation bay, and there's another child getting chest compressions, maybe about 14. And I'm hearing the story from the EMS who brought them in, and they're sisters. And this was a retaliation for gang violence that had happened a week before, that these two children were targeted and were victims of some sort of retaliatory gun violence. So I go help out with one of the kids, and we're giving blood, and she has gunshot wounds in her belly and in her chest, and we keep getting, so we're doing chest compressions, we're giving blood, and the emergency medicine people are running the code blue or the cardiac arrest. I'm also they're just helping out with the airway, whatever, and giving suggestions, things like that. We get ROSC. ROSC means return of spontaneous circulation, ROSC. That means we stop doing chest compressions. We have a heart rhythm. So we get that. We keep getting that. And we're like, oh, great. Maybe we can. The whole goal is to stabilize the patient enough to then go to the operating room to then open up the patient's abdomen, and then a surgeon can take care of whatever bleeders are going on. This is part of what trauma medicine is about. You stabilize the patient enough. If we're doing chest compressions, maybe we need, they need to get stabilized in the emergency department first. Anyway, so we keep, this patient, we keep losing her pulse and keep going back and back and back. Chest compressions, giving blood, losing pulse. So, but she wasn't really bleeding a whole lot. Anyway, we finally turn her to her side, and the back of her skull, there's just exposed brain tissue. Just kind of white, stringy brain tissue that's just out of the brain, out of the skull. So, when we all saw that, we knew that that was it. That's not a injury that can be repaired. so that patient was called dead at that time, unfortunately. Her sister did go to the operating room, but died there as well. There's no moral, there's no good end to that story. That's just trauma that those young patients went through, that their family went through, that everybody that helped resuscitate went through, that will carry with them the rest of their lives as a result of gun violence. And if you know anything about me and my TikTok, you know how I feel about gun restriction, gun control in the United States. It's morally repugnant, the rights that gun ownership has in this country. Anyway, that's all I have to say about that story. Sorry, that was not a fun story. Let's go to a better story with a better ending. So I had a patient who had a bunch of had a major back surgery, a bunch of hardware put in their spine, like up and down, like thoracic spine all the way down to their what's the word? Their sacrum. So it was a big back surgery, and then that all got infected, unfortunately, which can happen. That's not like something that the surgeon did wrong. It's just an inherent thing that can happen. So it all needed to come out. So I did anesthesia for this patient. It was a washout, opening up the back and washing out that infection out. Now this patient had something called HOCM, hypertrophic cardiomyopathy, which we called HOCM, and that's where that can be a cause of sudden cardiac death, where there's a little bit too much heart tissue in the way of the left. It's called the left ventricular outflow tract, the LVOT, of blood that pumps from the heart to the rest of the body, and it can impede flow of blood so much that it can cause someone to die. Now, so one of the key managements when you take care of someone with HOCM is you got to keep their heart rate low, because a high heart rate can make that obstruction worse. You want to keep their heart rate like 60 to 80. Don't really want to get higher than that. And you want to keep their what we call their preload and their afterload both up. The reason you want to do this, so if you're familiar with this language I'm saying, if not, don't worry about it. But you want to keep their preload and their afterload up because you're stenting open that LVOT tract by doing that. So you want to avoid wild swings in blood pressure. You want their SVR, their systemic vascular resistance, to stay nice and high, which can go low when we give anesthetics, and their preload can also drop when we give anesthetics. So you got to keep all these things in mind. You want to make sure they're in sinus rhythm. If they're in AFib or something, get them out of that. Anyway, you got to avoid all these things. So I knew all this stuff about this patient. So I took care of this patient, did the anesthesia for this patient for this washout. And guess how the patient did? The patient did great. I knew all these things, took care of this patient, boom, it was fine. Got through it just fine. Had a washout, but still had that infected hardware in place, and to get removed at a later date. So that all went fine. About 3 days later, now the patient is booked to have the hardware removed, and I happen to be the anesthesiologist who's also covering the case, and that was just a coincidence. If you're not familiar with anesthesia world, just because you take care of a patient a few days before, it doesn't mean you're the same anesthesiologist. It's the luck of the draw if you're on that same shift, etc. So I'm like, oh great, I know this patient perfect. I know she's got left ventricular outflow obstruction. She has this hypertrophic HOCM. So I was like, okay, I know how to treat this. The patient's going to do fine. But it was a big surgery. Getting all that hardware taken out, hours and hours and hours and hours. So patient, we get her off just fine. We induce with anesthesia. Everything's doing fine. We put in all these lines that are needed. Everything's going great. The patient is flipped onto her stomach. Her head is pinned by, like her skull is pinned so it doesn't move. And she's in a kind of a suspension on her stomach, on her belly, so that the surgeons can do their surgery. About 4 hours in, I come into the room. A nurse anesthetist is in the room with me, and they're providing primary anesthesia care while I'm supervising other rooms as well. And I'm looking at the arterial line tracing, which is the pulse, while I'm standing there, and it just kind of starts diminishing, and it flatlines. And I was like, is this real? Is this happening at this moment? And the nurse was like, the CRNA, the nurse anesthetist was like, yeah. So the patient is going to cardiac arrest 4 hours in. And believe me, we were doing our due diligence. The patient had blood loss, but the patient had plenty of blood, plenty of volume. We were doing all the things that we knew how to do for HOCM to make sure things weren't going wrong. And just put in perspective, this is now a patient who's in cardiac arrest. Their back is completely open in a surgical field. Surgeons are working in a sterile fashion. Patient is pinned, their head is pinned, they're on their belly, and they're in cardiac arrest. That's a big problem. So first thing we did was give some medications to get the blood pressure up, some vasopressin, lots of phenylephrine, gave him ephedrine. At this point, I had to give epinephrine. Of course, I want to avoid tachycardia in a patient who has HOCM, but the patient was not responding to any of those other vasopressors. At the same time, I'm telling the surgeons, this patient's in cardiac arrest. You need to bring in, and telling the nurse circulator, bring in a stretcher, bring it in. We need to flip the patient and do chest compressions. Now, I said those things very loudly and very directly, right? When something like that is happening, there's no like waffling, right? The surgeons want to hear what the anesthesiologist has to say. If something's wrong, they want to hear it very direct. So if you're an anesthesia provider or something like that, be direct. So I was like, the patient is in cardiac arrest. Bring the stretcher. We got to flip and start chest compressions. If I say something like that, everybody's moving, right? And I got to say that the surgeons just did a remarkable job putting down some quick kind of sterile packaging, some sterile dressing all over the back so it doesn't get infected, and just mobilizing. I mean, it was beautiful, how quickly they moved, these neurosurgeons. And then I called the code blue, in the United States, the code for cardiac arrest, and I got a bunch of support, a lot of other anesthesiologists in the room, lots of help right away, right, instantly. And before reflipping the patient, I noticed the patient starts rattling in the bed. And I was like, why is the patient light? Meaning the anesthetic's light. This doesn't make any sense. This patient should be deep. And I was like, why is this happening? And I looked down, and one of my colleagues is down there pumping from below with his fist on the patient's chest to do chest compressions. And you know what? It was working. I looked at the arterial line tracing, and it was generating a pulse. So that was really amazing. And that colleague, he's a great guy. He's also a critical care colleague that I work with. Anyway, so we flipped the patient to the stretcher onto her back. She's still in cardiac arrest. We did a round of CPR, and then the patient went into VTAC and got a shock. Came out of that, and then we got ROSC. Remember that ROSC, return of spontaneous circulation. So she was okay. So she had very limited time in a low flow state, meaning I wasn't very concerned about any neurological injury. So that's always something in the back of my mind when I'm resuscitating a patient, doing chest compressions and things like that. You want to think, how long is this patient not having good flow to their brain? Should I be concerned? Are we entering a medical futility zone? The zone of medical futility where we've been doing chest compressions and the brain has been in a low flow state for 30, 40, 50 minutes. And, the chances of meaningful neurological recovery really start going down the drain. That was not the case with this patient. Without a doubt, I was like, her brain is fine. She's going to neurologically recover from whatever low flow state that she was in during this cardiac arrest. But now I'm in this situation. So, me and all their care team. So we have this patient. Her back is completely open surgically. It's totally open. It's covered, but it's open. She's stable. But now I'm like, okay, one thing we need to figure out what happened. So I had one of my colleagues, a cardiac anesthesiologist, put a transesophageal echocardiogram down the patient's esophagus to look at the heart, and sure enough, we see obstruction going on. So we know that's the cause. Despite our best efforts, the patient went into this during the case. So she's stable, and she's not arresting again. So it's now, and this is where things get challenging. So you resuscitate a patient, but then a lot of times it's, what do you do? What do you do after you get ROSC? That's always the question to ask. And in this setting, I turn to our surgical staff, as a neurosurgeon. I'm like, what, is this patient's spine stable enough to leave the OR and go to the ICU? Because at this point, when you have cardiac arrest like this, you should stop the surgery and, you should abort and not expose the patient to dangerous anesthetics in an operation that's going to cause it to happen again. The surgeon was like, I need at least 45 minutes to put that spine in a stable enough spot so the patient doesn't have spinal injury. And I was like, all right. So basically what the surgeon is telling me, we cannot leave the operating room. They had much more work to do than 45 minutes. They had hours and hours ahead of them. But what he was saying is, I can stabilize the spine, get this patient to the ICU, stabilize the patient there, and then the patient come back to the operating room, another day. So I was like, okay, that's the situation we're faced with. So we made this decision and we had to put the patient back into pins, flip her back onto her belly, get everything going again, and to see how she does. She did great. We were able to get her back. The surgeon stabilized her spine. She went to the neuro ICU. She woke up there, she was totally neurologically intact. She had her spine fixed later in that week. She was extubated, totally neurologically intact. She did amazing. It was a great, very successful resuscitation, very big team effort. It was great. All right, let's go to the next story. So as a critical care doctor, I resuscitate and do chest compressions and all that stuff. I don't actually do chest right? As the team leader, I don't do chest compressions, right? I lead the team. Anyway, whatever. So I respond to many, many rooms where a patient is, dying or not doing well. So here's another story. There was a code blue called in a procedure room. A patient is getting an ERCP. What does that stand for? Sometimes there's acronyms you see and use for years over the years so many times you just forget the acronym, but you know what it is. It stands for endoscopic retrograde cholangiopancreatography, ERCP. Anyway, so the patient's in cardiac arrest. They go into the room and they're doing chest compressions, and everyone's trying to figure out what's going on, which is the typical thing. And I listen to the patient's lungs, et cetera, et cetera. They're still in cardiac arrest. So I had a prior episode where I talked about point of care ultrasound, right? Where you put an ultrasound on a patient's heart or lungs or belly to try to give us a clue about what's going on. And in this case, as we're doing chest compressions, I do that, and I take the cardiac probe and I put it on the heart. And what did I see? I see air bubbles everywhere. What I mean by that, not just in the right side of the heart. So when a nurse or an anesthesiologist, anesthetist just gives like an IV medication push through an IV, a little bit of bubbles gets through there, and that's normal. That's fine. A little bit of bubble going into the IV tubing that goes into the body, it's fine. Small volume bubbles are not harmful. Large volumes, like 20 cc's, 30 cc's, 40 cc's all at once, that's going to cause a problem. If you push a bunch of air into the right side of the heart, into the lungs, you might have obstruction of flow, and you could potentially cause cardiac arrest. But small bubbles, a little at a time, it's not a big deal. And oftentimes when I'm looking at a patient's heart, and in the ICU, and I have a cardiac probe on their chest, I can see I can see bubbles coming to the right side of the heart. And I'm like, you just, I'll look and I'll see the nurse just gave some medication. I'm like, oh, that explains the bubbles. And there's even a bubble test that we can do, that an ultrasonographer can do to look for a hole in the septum of the heart called a PFO, a patent foraminal value. That's a bubble test. And if you see bubbles crossing over from the right side to the left side of the heart, then maybe there's a PFO. And you can also visualize that with other methods. Anyway, so I saw air everywhere. What I mean by that, every chamber of the heart, I saw air. Full of air. That's unusual. There shouldn't be a bunch of air on the left side of the heart. That's weird. So I was basically like, I knew what happened. Some air had somehow been put into the vascular system, like carbon dioxide had been put into the vascular system. The patient had cardiac arrest from that. So you can have air, if you put enough air into a vein, through like a surgical procedure, enough air can get through the capillary system of the lungs and get to the left side of the heart and go out to the left side of the body. It can happen. So don't, if you're someone who knows what I'm talking about, like practitioner of some sort, it doesn't necessarily mean there's a PFO. If you get massive air going to the right side, it can get through the pulmonary vasculature. It can go to the left side, and this can cause cardiac arrest. It can cause air embolism to the brain, stuff like that. So immediately I saw that, I was like, this is air embolism, which is a complication that can happen from a procedure like this. It's rare, but it's a possibility. It's one of those risks that should be discussed. Ultimately, that patient did fine. We got the patient back, and it wasn't so much air that it didn't overcome the system, and it didn't go to the brain. I mean, sure, of course some got to the brain, but it wasn't enough that it overloaded the organs, so that it didn't cause ischemia time, ischemic injury to the organs. And that patient did just fine, absolutely fine. All right, let's see, another story. So there was a patient who was fairly young who had a history of something called Prince-Metal coronary artery disease, which is or I should say Prince-Metal vasospasm, where the vessels to your heart, when those get blocked, that can cause a heart attack. But this patient had this disease where those vessels spasm at random times, very severe, and causing her to go into cardiac arrest. And she had a known history of this, and had been treated in the ICU and had left the ICU many times, several times before. And it was so bad at the point that there was even ideas floating of her getting a heart transplant. Anyway, so I was on the ECMO service as a ECMO attending, fielding consults, and I heard about this patient in a different hospital that I knew was there. She was getting transferred here to our cardiac ICU, not the cardiac surgical ICU, which is where I was attending, but cardiac ICU. And the attending there gave me, who's very, 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 very smart guy. I highly respect his opinion about a lot of things. And when he talks to me, I listen. And he was like, here, this patient's coming. I'm a little worried about her. We'll see what we can do here. But I wonder if she needs to eventually go on ECMO as a heart transplant candidate. I was like, yeah. And I looked up her chart, and I was very worried about her as well. So she finally got to our main campus, and I went and saw her, and she was not doing well. She was on very high dose epinephrine, norepinephrine, and vasopressin, very, very high doses. The attending I was talking to was floating a Swan catheter, a Swan-Ganz catheter, or a PA, a pulmonary artery catheter, to get more numbers. And as we're standing there, and I came in and saw her, I mean, she was on extremely high doses of these things and really clamped down. Her vessels were very clamped down. She was in cardiogenic shock, really doing poorly. And she had no contraindications, right? So I make a decision on the spot about if a patient should be put on ECMO. And I'm talking VA ECMO, veno-arterial ECMO, for cardiac arrest or for, heart failure. She was in cardiogenic shock, obviously. And I was like, this is a young patient, relatively young. And she doesn't have any known, she doesn't have any neurological injury. She was intubated at this time as well. She had a breathing tube. She doesn't have any known neurological injury. She doesn't have any advanced cancer. So she was checking all my boxes. And he was like, what do you think? Should we put this patient on ECMO? I'm like, yes, let's do it right now because she's going to arrest. And it was like the moment I said that, she went into cardiac arrest, and we were doing chest compressions. So I activated ECMO, and it was just a beautiful ballet of, wait, that's an exaggeration. It was not a beautiful ballet. What this means is, so when I activate ECMO, a bunch of people come. Bunch of resources. The ECMO machine comes, all of the materials, all of the equipment needed to put that patient on ECMO arrives. It also alerts a cardiothoracic surgeon to come. But since all those things were out, I started just putting, they're doing chest compressions, the cardiac team. So I started prepping the patient's groin, putting needles in the femoral vessels, getting access, IV access, or getting, central access, and ECMO machine, all that stuff came. Other help came. A cardiothoracic surgeon eventually showed up. Another colleague of mine showed up, and together we all put this patient on VA ECMO. And it took about 30 minutes, which is pretty good. That's a pretty good number. While we're doing chest compressions, we got her on, and then we were worried about immediately from there. She went down to IR, or I should say the cardiac cath lab. because we had them place a distal perfusion catheter, if you're interested in knowing what that is, to help preserve the leg, because one of our ECMO catheters can block blood flow to the leg, and you can lose your leg. It can die. So that was placed, and then an impella we also had placed in the left side of the heart, because I can talk about it, and I've talked about it in other episodes. When you put someone on VA ECMO, and if their heart is not pumping very well, that retrograde flow can distend the left ventricle, and it can kill the left ventricle. And the idea for this patient is either she's going to recover or she needs a heart transplant. It's one or the other. So the impella it's a small pump that we snake, that I don't do it, but an interventionist does. You snake it up into the LV, the left ventricle, and it's a small pump that helps to continually decompress the LV so you don't have overdistension, so you don't kill the heart, basically. So that was placed. So we successfully placed the patient on that, and the patient was listed for a heart transplant and received a heart transplant. So that was a very, very, that was the intended outcome with that, by emergently placing someone on VA ECMO, and that is a part of my job. That's one of the things that I do. All right, sorry, that's it for story time. I know I wish I had time to do more, but I can do more podcasts like this. I obviously have story after story after story I can share. Let's move on to our book discussion for this week. The book is called Evil Geniuses: The Unmaking of America by Kurt Andersen. The guy's an author. He's been a host of public radio. This dude has been he's done a lot of stuff. He's been a co-editor at magazines. He's been a columnist for New York, the New Yorker, other stuff. He's a smart guy. I follow him on Twitter. Anyway, I was kind of reluctant to read this book because for one thing, the title and the cover looks like it's very conspiratorial, but that's not what this book is. This was written in 2020, August 2020. It's about 430 pages. This book is about neoliberalism. And I guess I was really, so despite my hesitancy to read the book based on how it was marketed, I really found an engaging and really poignant, well-researched catalog of the events leading to modern America, where we're at right now, how we arrived at this spot. And this book really covers a lot of important details. The bulk of the book addresses the big elephant in the room, which is big business control since the 1980s has led to ballooning wealth concentration and disparity not seen since the 1920s. He gives a really welcomed but brief history of America from the 1700s to the 1960s, and then really zooms in on the recent 50 years, decades, and the crucial events, the culture and decisions that were made, which have steered us towards a very real dystopia in which Americans and Western countries very much live in today. Andersen really brings a timely phrase into my mind: the political economy. That is, how the existing economy is shaped, molded, and codified by whoever is in control, regardless of actual economic metrics. The changes wrought in the 1960s brought America into a cultural and economic flux. Turnover of ideas, fashion, tastes, and television became an expected part of American life. At this time, overt greed and big business takeover was something generally abhorred by the public, particularly with the rejection of Barry Goldwater, the fringe libertarian, conservative libertarian presidential candidate who lost to LBJ. By the time the 1970s rolled around and the business roundtable, which included business elites like the Kochs and the Coors and Scaife and others, they put forth a unified effort to normalize big business once more by way of influencing politics and culture through the proliferation of political think tanks, which behave as tax shelters. The Powell memo provided the manifesto for this group, from which has also borne Supreme Court Justices Scalia and Kavanaugh. The plan for the Business Roundtable came to fruition with the very deliberate offering of Ronald Reagan to the public, who condemned big government and executed unfettered deregulation of big business through various policies. The rightward shift into deep neoliberalism dragged the entire country, including liberals, to the right. What follows was a pandering class of politicians, whether they're Democrats or Republicans, who now court the American public through the 1990s and into the 2000s with ideas normalizing big business takeover of American politics. Needless to say, the pro-business policy making for the last 40 years has completely undermined the working class, while they enjoy no appreciable gains in median household income in the same amount of time. All the while, the only people that have profited are the mega rich. There is no evidence from the last 40 years that trickle-down economics is a viable model of prosperity. In my opinion, the experiment should be over. Andersen touches on the Trump administration, the tax plan of 2017, which is a neoliberal tour de force that balloons public debt without seeing long-term gains for the average American. Trump is in both ways more of the same, but with a demagogic twist, right? He is clearly perpetrating the corporate self-interest of his predecessors while more blatantly using the tried and true scapegoats of nativism and racism to garner and kind of consolidate public support. It goes without saying that the libertarian policymaking left us very ill prepared for COVID-19. Besides the expert cataloging of the events I just talked about, Andersen in this book puts forth some interesting theories. He proposes that America has been in cultural stasis for 20 to 30 years without changing tastes. As opposed to the 1960s, Americans actually fear the future now and are very easily manipulated by the powerful force of nostalgia. Nostalgia for the imagined yesteryear of prosperity and stability. Marketers and politicians know this, and they capitalize on that nostalgic effect. I was really happy to find that Andersen offers some pretty good solutions. He argues that 2020, when this was written, is indeed an inflection point, but it's not the first inflection point we've ever had. We very clearly mirror conditions of the 1920s. There's no doubt that if the political economy doesn't have deliberate change, this system will break. It will break again, and it will continue to break. It'll probably break off. Andersen offers some familiar solutions, such as a much-needed wealth tax, increasing the estate taxes, which Trump's 2017 tax plan completely got rid of, and then increasing corporate taxes. He also mentions UBI, Universal Basic Income, and how Alaska has been thriving off of a corporate oil subsidy and has been doing just fine with production. The most poignant solution he offers was this. The public must change from a binary ideological system. It's not that all regulation is bad or that all socialism is good or vice versa. Thriving modern societies live on a spectrum of both capitalistic and socialistic ideas that reign in one another. We must embrace ideological, non-binary decision-making. For me, that is the key. And young people clearly think in more non-binary ways than their parents do. So I really did enjoy this book. He does a fantastic job of keeping you engaged. If you enjoy books like Dark Money by, what's her name, Meyer, Shock Doctrine by Naomi Klein, or anything by Chomsky, I do recommend this book. All right, I'm going to answer a question from TikTok. This is from @Frost13721. This person asks, "What are your thoughts are beginning the process of becoming a doctor as a second career? I'm 32 and am thinking about starting." So it's a great question. So right off the bat, you can become a doctor at any age. You can go back to school at any age. There's no timeline. Don't let anyone think that you need to adhere to a timeline. Oh, I didn't do this at this time. I didn't do that at that time. The ship has sailed. There's no ship. You get on it whenever you want. So obviously there's going to be advantages and disadvantages about you do anything at any time of your life. If you start med school later, like at the age of 32, assuming you've already done 4 years of college, which you need in the United States, and then 4 years of med school on top of that, so you'd be 36, and then a residency on top of that. If you did just internal medicine, that would just be 3 years, so you'd be 39. But if you did something else like anesthesia or like neurosurgery or cardiothoracic surgery, you could be well into your 40s, mid 40s, before you even start independent practice on your own. So what are the downsides of that? Well, if you have to take out loans, you're not making a salary while you're a med student and while you're a resident. You are making as a resident, but it's not salary that, it's just to live on. It's not much you can do with it. I couldn't save anything or pay off any loans. And then you're missing on other salary that you would have on another job. So you could be missing on savings and investment and things like that. And then, and now it's possible you have a lot of loans, and now you're in your 40s and you're now beginning to pay off those loans. Often it can take 10 years to pay off those loans. And now you may be in a career that's lucrative enough that that makes up for it, but not all. So physicians are well paid in the United States, but it's a huge range, right? it's a huge range. If you go into psychiatry or family medicine, that's low paying relatively. It's still a good job, it's still a good salary, all things considered. So there's a lot of things to balance. It's not, what I would say is you don't want to be held back just because, society doesn't usually do that way. That's fine. Whatever, do whatever you want. But you need to also balance it. Like, is this the right thing for you in your life? Do you have a family? Do you have children? Is it the right thing for them for you to do this? If someone's 32, whatever. I started med school when I was 25, a little bit later than a normal person, still very young, of course. And it worked out just, really, really well for me. All right, that'll do it for this week. Thanks for listening. Please leave a review if you haven't already. That helps expose the podcast to more people. Share it. Let me know if you have any ideas or if you have comments or feedback for me. My email is icudoctorecmo, ECMO @gmail. I'm on TikTok it's just ICU Doctor. And then Instagram, you can also direct DM me on Instagram at ICU Doctor TikTok. And I usually get to most of those messages pretty quick. So thanks for listening. I'll see you next week. Have a good one. Thank you.